Our next speaker, I'm so happy to be able to present Dr. Farzin, who is going to be speaking to us on psychedelics. So, Dr. Farzin is a family physician focusing on the applied sciences of psychedelic-assisted therapies, nutrition, and lifestyle modification for trauma, existential distress, and wellness. His practice deals with combining emerging treatments and digital health technologies with mindfulness, music, and psychedelic medicine to improve quality of life, promote healing, and alleviate suffering at all stages of life. He is an attending physician in the Division of Palliative Care at the Jewish General Hospital in Montreal, and he's a lecturer at McGill University's medical school, where he earned his medical degree and completed his residency training. His involvement with McGill programs in whole person care includes teaching mindful medical practice and resilience to medical students. So please join me in giving him a warm welcome. I think we're in for a treat.
Thank you for that kind introduction and giving me the space. Can everyone hear me well? Yep. Great. So I'm going to keep it stimulating, given it's right after lunch. We're talking about an exciting emerging therapy using psychedelics, and today we'll get into the sort of palliative care experience we've had. So I am involved with a number of projects, mostly nonprofit. The main one pertaining to today's activities is TheraSil. It's a British Columbia-based nonprofit that essentially paved the path for legal access to psilocybin-assisted therapy in Canada. I train through their sort of platform, and I'm part of the training and ethics committees. And I'm involved with MAPS. That's a US-based nonprofit bringing MDMA-assisted therapy for PTSD. That's being submitted for FDA approval, and that's another exciting area. The only for-profit sort of involvement is an investment, small amount, as an early investor in Beckley SciTech, and they're a for-profit company developing psychedelic treatments in Europe. So we're going to review the evidence for psychedelics in this palliative care context, discuss the various sort of elements of their role, and also talk about the experience that we've had over the past 2 years or so. And these are the competencies that we'll practice. So the definition of the word psychedelic, it's important to know, it was coined in 1956 by British-born Canadian psychiatrist Humphrey Osmond, and it sort of broadly means mind manifesting. And so from Greek roots, the idea is that these sorts of compounds enable the expression of parts of our psyche that are normally in the subconscious. And so they bring to our consciousness things that are not normally accessible. And so with that definition, that was given initially to what are known as classical psychedelics, like LSD and mescaline. We're applying that definition out to a broader set of substances that work differently from like a neurophysiological perspective, but also facilitate this process of manifesting what sits in the subconscious. And so in that category, MDMA and ketamine are now also classified by many as psychedelics. So the compound that we'll focus on today is the one that's available to us now, and that is psilocybin. It's the active ingredient in what are known as magic mushrooms. Psilocybin is a serotonin 2A agonist, and what that means is it basically stimulates certain part of the serotonergic system in the brain, which is a very fundamental sort of pathway of neurotransmitters that create change. And LSD, which a lot of the early research was done on, looks a lot like psilocybin and also acts on the same system, and they both resemble the neurotransmitter serotonin. So if we want to get an idea of what happens in the brain when we're having these psychedelic experiences, The normal sort of picture is on the left. In our ordinary state of consciousness, we have some communication between the various regions in the brain. And what happens in this heightened state is we have new communications, and a lot more of them across various different parts of the brain. So there's a fundamental shift in how we perceive things, and sort of experiencing senses that are abnormal and unordinary. For example, the term synesthesia describes when the senses are switched. So let's say you can taste sound or see sound and things like that. And that relates to how the brain regions communicate with each other. Just to show you that the magic mushrooms actually very distributed widely across the world. And so including in Quebec, we have like a native species. And there's lots of evidence for its use. These are cave paintings, thousands of years old, ranging from Algeria, Siberia, Spain, and most notably in the Americas, we had indigenous practices using these mushrooms in ceremonial healing contexts, and that is sort of how it came into Western culture. I'm also going to point out that in the Greek sort of traditions, there was a 2,000-year-long ceremonial sort of use of some sort of psychedelic called kykeon. It's hypothesized that it was an ergot substance, which is like LSD, and the Eleusinian mysteries are what they were called. On the right top, we have sort of the Persian use of a compound named Houman, and on the bottom is the Indian Rig Veda, and they used soma. So all that to say that we've had sort of ceremonial use of mind-altering agents in various cultures. So on the left, we see this Life magazine article from 1957, and this gentleman here is a New York banker by the name of Gordon Wasson, who was an amateur mycologist. So he studied mushrooms. He heard about the use of these mushrooms in Oaxaca, Mexico. He traveled there. He had a ceremony with a famous local shaman called Maria Sabina, and he brought back the psilocybin mushrooms to America, started having it analyzed to find out what the active ingredient is, and essentially through this Life magazine article popularized it in society. And on the right, we see an image of Albert Houman, Swiss chemist who actually accidentally invented LSD and accidentally got exposed to it and then intentionally took it. And he's actually the guy who also purified psilocybin. And so what happened in the 50s is they started shipping LSD. So this is under Sandoz, the pharmaceutical company, started shipping LSD to various sort of researchers across the world. And a number of patients were treated with LSD, actually tens of thousands of them. And you had close to 1,000 papers published in a short amount of time. And what sort of evolved out of that was a combination of shamanic practices with Western psychotherapy to develop this model of psychedelic assisted therapy that is a psychotherapeutic process, ultimately with sort of infusion of certain shamanic indigenous principles. And so that involves plenty of preparation, having the psychedelic experience, and plenty of integration. And so during the preparation, which is done over weeks, sometimes months, you establish trust and a therapeutic relationship, and you sort of explore the phenomenological experience that lies ahead. In the case of palliative care, this is an opportunity to really explore where the person's coming from, what their sort of psychosocial history is, what their sort of goals in life, the meaning they have in life, what they want for their end of life. And in the integration, you have an opportunity to essentially integrate what comes out of these sessions into their life and create change. So Canada actually has a very important part in psychedelic history. So like I mentioned on the left, that's Humphrey Osmond, who invented the term. and that's Abraham Hoffer, and they worked together in Saskatchewan at this Weyburn Hospital, treating patients. A lot of that work was related to alcoholism at the time, and they had very good results using LSD psychotherapy for alcoholism. Actually, Abraham Hoffer's son is a staff at the Jewish General Hospital, and so he has a lot of fond memories of his father. And I'll talk about the historical timeline of the Spring Grove experiment, which is another major sort of focal point of early research into psychedelics, where they essentially started treating schizophrenics with LSD and getting really interesting results. At that point, LSD was seen more as a psychotomimetic, which means something that induces symptoms like psychosis. And that's why they were giving it to the schizophrenics. And what happened is one of the researchers, who was like a relatively young researcher, got metastatic breast cancer. And so, she got a liver diagnosis after that, and she became devastated, like a classical picture of what we see happen in palliative care. And there was some basic early evidence suggesting safety of using LSD with sort of chemotherapy. And so she was the first patient that had this sort of experience for the palliative indication with very positive results. And I think it's worth reading her account from that initial experience. Mainly, I remember two experiences. I was alone in a timeless world with no boundaries. There was no atmosphere, no color, no imagery, but there may have been light. Suddenly, I recognized that I was a moment in time, created by those before me, and in turn, the creator of others. This was my moment, and my major function had been completed. By being born, I had given meaning to my parents' existence. And the second one, again in the void, alone without the time-space boundaries, life reduced itself over and over again to the least common denominator. I cannot remember the logic of the experience, but I became poignantly aware that the core of life is love. And this is a theme we see a lot. This is love at the core. And at this moment, I felt that I was reaching out to the world, to all people, but especially to those closest to me. I wept long for the wasted years, the search for identity in false places, the neglected opportunities, the emotional energy lost in basically meaningless pursuits. And I think this speaks highly of what this therapy can offer. And part of it is really just bringing to surface things that are perhaps bothering us, but that we don't have sort of direct access to. And this is what happens in psychotherapy, psychoanalysis. I mean, this is sort of the core of that. And psychedelics are a catalyst to this experience that also is echoed in mindfulness practices, actually. So after that, there was a wave of research, a lot of positive results coming out using LSD for patients with advanced cancer. And unfortunately, that came to a halt with sort of the war on drugs and the prohibition that followed. So these are articles related to psilocybin, which wasn't even as commonly used in research, but we sort of see how there was a dip and then a sort of resurgence. And so these three articles were super important in reviving the sort of current movement of using psilocybin in adjunct with psychotherapy for patients with advanced cancer. First one was at UCLA, and that set the tone for the second two that you see at Johns Hopkins and NYU, two randomized controlled trials with extremely positive results. And currently, these three sites are doing a multi-site randomized controlled trial that, when published, will be like a very definitive sort of evidence. And these studies were the ones that were used in Canada, actually, to convince Health Canada to give us access, essentially. And so all psychedelics considered, this is sort of the wave of research that has emerged, and it keeps going up. There's a lot of research taking place, a lot of big changes happening, and you're going to see psychedelics sort of introduced into the mainstream in the years to come. And so to summarize the evidence from the Johns Hopkins and NYU studies, despite the fact that we have to understand research is selective, so patients are selected. And so if we sort of use the selection criteria in these studies, these results are applicable to the majority of patients. And so the results are that the psilocybin therapy, which, like I said, is similar to LSD but a lot shorter acting, is safe, effective, and enduring, with large decreases in measures of depressed mood and anxiety, increased quality of life, life meaning and optimism, decreases in death anxiety, with changes sustained in 80% of participants at the 9-month follow-up. No medical or psychiatric serious adverse events, and only mild elevations in BP, blood pressure, headache, nausea, vomiting, and that individuals with mystical experiences had a greater positive sort of outcome. And so the way the mystical experience is measured is through a questionnaire. It's called the Mystical Experience Questionnaire, and this is a process that's taken about a century to evolve from the work of William James, and it was essentially Pankey, which was one of the main researchers, that sort of categorized it. But this experience of mysticism that people have sometimes in a religious context, or just in nature, or even just serendipitously, is a sense of union, transcendence, sacredness, deeply positive felt mood, ineffability, paradoxicality, transiency. And so these experiences, especially with this palliative application of this treatment, seem to be very beneficial. It's an idea of sort of transcendence of time and space. And so work has been done on this mystical state. One of the pioneers of this work was Roland Griffiths at Johns Hopkins, and he passed away about a month ago. I highly recommend looking up some videos from Roland Griffiths. Towards the end of his life, actually, over the past year, he got an unexpected diagnosis of advanced cancer. And as someone who did all this research, he talks beautifully about what he saw in his patients, and then he experienced it himself. And so, in the study that he did, this experience with psilocybin was one of the top 5 most meaningful spiritual experiences in patients' lives, and we see that echoed in our work. And so the idea about meaning making, everything that's been said today is relevant to this talk and complementary. So the idea is that we're creating an experience to shift the attitude, and that can be done literally until the end of life. That being said, we don't treat patients that have a prognosis of less than 3 months if they have major, functional impairment. So if they're bedbound, or if they have major organ dysfunction, like if the liver is not functioning, kidney is not functioning. So there are limits. As research comes out, we'll be able to sort of expand that. Currently, Dr. Sanders and I are trying to get funding for a study that's like a phase 2 clinical trial treating patients in this way. And so psilocybin became illegal in the United States in 73 and in 74 Canada. And so that continued until August 2020, when these Section 56 exemptions were approved for 4 terminal patients. Section 56 exemption is a particular sort of exemption that Health Canada gives to patients. And this is the same sort of initial legal framework for cannabis as well. It started with a Section 56 exemption. And so the first training cohort with Therasil, and Therasil is that nonprofit I mentioned that actually got those exemptions approved. The first training cohort also got permission to use psilocybin for experiential learning. And since then, no one else has been approved. And in Quebec, the first Section 56 approval was in January of 21. I'll briefly talk about that case. And then in January of 2022, psilocybin and MDMA were added to the Special Access Program. And so, has anyone heard of the Special Access Program? Raise your hands. A few people. So the Special Access Program is a program by Health Canada that allows you to bring medications that aren't approved for patients that need it a lot. And so, for example, in the HIV days, this was used to bring in HIV drugs. Currently, a lot of chemotherapy agents that aren't approved in Canada are provided through a special access program. And so, Health Canada allowed psilocybin to be added to the special access program, and we started treating patients about 1.5 years ago. And so this is some unpublished result from a study we did 1 year ago, and it just echoes on the left that most people haven't heard of the special access program. And in terms of the recognized benefits of psilocybin, it's getting more and more media coverage these days. But the minority of people have heard of its use for anxiety, depression, PTSD, and existential distress. On the bottom right, we see that 76% of the people were aware of existential distress to be a common condition in palliative care. So that's a good thing. And this study that I'm talking about is called P3A, and it's led by a professor at University of Laval in Quebec City. And we're hoping to continue this and sort of roll out this end-of-life use of psilocybin in Quebec. The study I mentioned is actually across 4 provinces. It's important to note that it's a relatively educated sample size, so everyone has at least a bachelor's degree, and that the minority of people there had actually tried psilocybin. On that note of the survey, really, this is showing, the column on the left is that people are approving the current system we have, which is when a trained sort of healthcare professional gets an exemption from Health Canada and does this treatment, rather than a lot of other more common methods, actually. So what's called the underground is essentially illegal use of psychedelics to help treat people outside of the medical system. These sort of treatments are very hard to access now, and so people are forced to go to the underground, but that the majority of people actually prefer it to be in the medical system the way we're doing it now. And so in terms of favoring coverage of the cost of this therapy, which is very expensive, so every patient requires 2 therapists. The sessions themselves run sort of between 6 to 8 hours, sometimes longer, and this is separate from all the preparation psychotherapy, all the integration psychotherapy. It's at least something like 40 hours of therapy per treatment, and so it's very expensive, and you need 2 therapists for most of the process. But majority of people are in favor of covering at least some of the cost, and we see about half people would favor all of it covered. And with that, I'm proud to say in Quebec we were able to get at least family doctors covered. So family doctors that are doing psychedelic-assisted therapy are getting reimbursed by the RAMQ. This is one of the first in the world. And so that's one way to sort of cut cost and bring access. So this is the first patient I mentioned. She got her Section 56 exemption, but unfortunately her oncologist was against her use of the medication, despite the fact that she had basically first 1 stage 4 cancer and later diagnosed with the 2nd stage 4 cancer. And unfortunately, by the time that the oncologist sort of told her that there's nothing else to offer, and she came back wanting the psilocybin therapy, we weren't able to offer it because she was too sick. She was at the end of life. This is a photo from her home, and I must say it's just beautiful to see people talk about all the services offered here, and places like Teresa del Art and Maison Saint Raphael, Hope and Cope. But just offering these services for free to patients is amazing, and it goes a long way. But this patient wasn't able to be treated, and that's just to say that we have stigma that needs to be sort of addressed through education, and so that's what we're trying to do. This is a photo of the first patient treated. The first few patients treated were treated at home. So this was pretty much like a home care, palliative care type service. And this patient has actually, we've done 4 treatments for her, and she's done remarkably well. And I'll talk more about this documentary coming up where she actually shares a lot of her journey, and the third session was filmed actually by the documentary crew. This is a drawing that she drew. So I'm going to go through a few sort of examples of patient experience. And so in this image, we see her face. This is the image she drew after her first session, which was a very difficult one. And so you see that she's sort of surrounded by this dark cloud. And that is her ordinary experience of life, is surrounded by this sort of darkness. And if you look where her heart is tapping into a world of color that is actually there, but she doesn't have access to it. So through this experience, she was able to sort of get a glimpse of what the possibilities are. And since then, we've done a lot of work, and she's in a very beautiful place now. This is another patient that was treated. He's been very public about his treatment. And I'm going to play a video here just showing the difficulty that can arise during a session, but also its effectiveness. And I'm going to be using something called internal family systems, which is a mode of therapy where we talk about how different parts inside have a function, that the parts aren't bad. And so we try to sort of create a whole approach to being. So I'll play this video.
Oh, shit. That's okay. Fuck it. That's okay. Get angry. Fuck it. It's okay. You know, I hate being this person. Yeah. I hate it. Yeah. You know? Yeah. I fucking hate it, man. Yeah. Fucking hate it.
I think, these parts served a function at some point when you were born.
Much wiser than I ever am.
So just to say that, these experiences can be very challenging, and there's an art that goes into sort of helping patients go through the process. It's mostly non-directive, so, they call it holding space. So someone that's sitting with them during the experience isn't necessarily, bringing in too much from their own perspective, but if the patient's in a difficult place, you can help them sort of reorient. And this patient, after that moment, was able to trust, be open, let go, and cried for about 3 hours. And that was more than he's ever cried in his life, he said. And this was the outcome. Oh, it's not showing the video. Actually, yeah. This is the outcome.
Every day I look at the world from my window.
So, powerful experience. He's still in a good state, thankfully. And we see that, in that sort of difficulty, once he was able to accept, he surrendered, and there's this humility. He had a sort of a religious background, and so he had a very religious experience, and that helped him a lot. And the ultimate result was the euphoria. This is another patient that we treated. He actually spent the last few months of his life in his chalet in the Laurentians. And this patient was actually the first patient that was treated under the special access. And he actually opted for MAID not too long after. But this is an example of how we were able to offer patient-centered care, in his home, sort of with his cat. And this is the benefit of what we can do in Canada, which is offer this sort of compassionate care outside of the context of a clinical trial. In clinical trials, you have to be very strict on what you can do and what the patient can do. And we don't have time to get into details, but he had a very beautiful mystical experience. I actually wrote an article on it. If anyone's interested, this one's available for free on the McGill Programs for Whole Person Care journal. And I'll just talk about this case quickly. And this is just another patient, a retired nurse, suffering immensely. And she had another beautiful experience, and sent this flower the day after, sort of saying that the flowers have blossomed, thank you. And it was just a reflection of what happened inside. This is a patient that was suffering so much that she couldn't listen to music because listening to music, although she loved music, she couldn't listen to it because it was too painful. It took her back to the memories and then to the pain of losing all the things she had. And so she's been listening to music again. And this one, we don't have to read through it, but really this is like from the last patient we treated. And this is a patient in her 50s with breast cancer. And, you know, we talked about poetry, like she called poetry her first love. So as a teenager, she wrote poetry, and she could only get into these states to be able to write poetry, you know, in a very particular time, so she can't usually access it. But she wrote this poem that she brought to the session and put on the altar. And the session, the poem, you know, she didn't really understand where it came from, but during her session, she realized that her inner child was essentially writing this message to her for her to be able to sort of come out of her role as an adult, which she took on very young. So as a child, she started being the caregiver of her family, and this is what we've seen a lot. People, you know, at a young age assume responsibility and sacrifice their childhood. And so now she's back in communication with her inner child and more and more active, writing poetry and other forms of art. Very healing. I want to finish with talking about the sort of indigenous perspective, which more and more I see, especially at McGill. I'm really proud to be part of the Department of Family Medicine at McGill because they're bringing in a bunch of indigenous academics. McGill actually this year, I think, enlisted around 11 or 12 major academic positions to indigenous community, and Department of Family Medicine has a few, and it's just lovely to see. But just to compare the Western worldview to the indigenous view, and this is taken from a book called Wisdom of the Elders that was published in '92 by David Suzuki and Peter Knudsen. And so we see that in the Western worldview, the universe is compartmentalized in dualistic forms and reduced to progressively smaller conceptual parts. This is sort of our scientific process is reductionistic, and we've achieved a lot through it. But it's worth comparing it to the indigenous worldview, which says the universe is viewed as a holistic, integrative system with a unifying life force. In the Western, we have time as a linear chronology of human progress. In indigenous, we say time is circular with natural cycles that sustain all life. And Western says nature is completely decipherable to the rational human mind, and indigenous says nature will always possess unfathomable mysteries. And so that's one of the things. This work, there's a lot of mystery to it. We don't fully understand what's going on, and so we have to respect that. Just to say that the sort of new frontier of being able to offer this therapy to more people is to do group therapy. So this is a group out in Maryland that has a new model for group therapy. And so they do 3 to 4 individuals at the same time. They go through the preparation together. During the sort of dosing session, they're in separate rooms with their own therapist. And then they come back together for integration, and this reduces the number of therapists required. Normally 2 per person gets reduced in this way. And so I'm proud to say that we were able to do the first group therapy in Quebec recently. This was done at the Hope and Cope Wellness Center, thanks to Suzanne for her support, Dr. Zigbee for his support. And so this was covered in the news just 2 days ago. And so we see that, you know, we had 3 therapists present for 2 patients treated simultaneously, which means just by combining 2 patients, we needed 1 less therapist, which if you think about 40 hours is a lot. And then the patients also get to sort of help support each other. You know, just like we talked about these other sort of group therapies that take place, they're able to help each other, and they're able to come out of that isolation and connect with their peers in a different way. There is a documentary this Sunday at 6:30 p.m. in French, Découverte on Radio Canada, that's going to cover the psilocybin-assisted therapy. So if you have time, you should watch it. And I'll just end by saying, you know, what we've learned is the importance of whole person care, and that the mystical experience doesn't eliminate suffering, But just because the mystical experience doesn't eliminate suffering doesn't take away from the value of a mystical experience. So the mystical experience has proven to be really valuable for many patients. And, you know, there's all this question of MAID being offered, the medical aid in dying. You know, patients should have a right to this sort of experience if they want to, if they have the right to die in the medical system. And, but this experience isn't necessarily going to change their mind about doing MAID. In fact, the patient that we treated was more comfortable with death, and so he had MAID even sooner than he had planned. And it's overall very complex and multifactorial. And it's really important to set realistic expectations. You know, right now there's a lot of interest in this, and people are reaching out really expecting an instant cure, and that is not the case. This is not a silver bullet. A lot of times patients do this to see what kind of work they need to do in order to feel better, and that work could take months. So integration is really important. The experience itself gives you certain sort of lessons, but you have to take time and integrate that. You know, make changes in your emotional sort of patterns, thought patterns to actually benefit. And so establishing support systems, more options for group therapy, public and professional education, and keeping humility and reverence, very important in this work. And 35 minutes, so we have some time for questions. Thank you.
Thank you Thank you so much. That was a fascinating talk. I want to open it up to questions, and I'll check to see if anyone has asked questions on the chat.
Hello, I don't mean to take all the mic time. I'm just a curious guy. Do you know if there's any research being done or having been done with combining this with immersive technology, such as virtual reality? I can't keep from thinking about what we're doing with medical hypnosis and mixing it with not for distraction, but really as a way of playing the trance with both methods. Is there anything like that?
Thanks for the question. Yeah, one of the things I didn't mention is actually with hypnosis, there's a major overlap. And
Yes.
this sort of brain circuitry involved, the process, hypnosis actually really falls along psychedelics. So there's a lot of work being done with that in general. The majority of work being done is how can we create these experiences without the substances? And so there's a lot of work being done using virtual reality technology and other immersive technologies to recreate sort of the altered state, either as preparation for the real deal or to replace the real deal, because a lot of people might not want the experience or not be physiologically fit for the experience, like at the end of life, actually. So this is really nice to see this Rivka's work with Dr. Zigbee. So the main use has been focused on that, and part of it is when you're in this altered state, you know, your vision is distorted, it's hard to have like the technology, and the bright light usually bothers you and things like that. So, you know, we use music and scent and things like that and touch. But, you know, when you're on the substance itself, there's not as much use for that. But pre, post, or as a replacement, there's a lot of research, a lot of companies now are actually working on that.
Well, we love working with the scientists, so if you have anything you want to do,
Definitely. Yeah. We should chat. Thank you.
I'm just curious, Houman, I thought part of the psychedelic effect, apart from the mystical experience, was also the plasticity in the brain, which is where integration becomes very important. So I could imagine that, you know, as the former person that was asking, you know, can we do this without all, like with virtual reality, et cetera, but without the substance, we might not be able to get the full effect because you don't get that plasticity, or it might take such a long time, like CBT. So it's just a question.
No, that's a good question. I didn't talk about the neuroplasticity here, but that's a very important part of this whole thing, is that, you know, in addition to the communication changes that you see in the brain, there's this ability to sort of make new connections easier. And so you actually have dendrite growth when you do sort of preclinical research. There's a clear growth in dendrites in the nerve cells. So the plasticity is definitely a huge component. And yeah, this is like a catalyst that super powers whatever process takes place through these other modalities. So thanks for talking about it.
Thank you so much for that talk, Houman. It was honestly, every time I hear it, I learn something even more interesting. My question is, going back to some of the earlier studies, I know that there's a lot of papers that are very early and they may not be easy to access. How early on in advanced disease do you think that it might be helpful? I'm just trying to think about, how much time it takes to process and integrate a lot of the experiences, and I keep thinking about how quickly something becomes very stressful when you get a diagnosis of a metastatic disease. Integrating this earlier on strikes me as being intuitively the right direction to go, but again, I'm just wondering whether there was any data to support that.
Thanks. Yeah, I mean, I'll share first my personal view is that this should be early. Like, the concept of early palliative care, as most people know, is that it actually, can help patients do better in their course of illness, and that's what the, early evidence shows. Fortunately, I think if someone has a real, like stage 4, let's say cancer, or high risk of recurrence, we can sort of justify with Health Canada and get access early. I think the earlier the better. Again, the patient that ended up doing MAID, he called us to thank us just like 2-3 days before his date to pass, and all he had to say was, keep doing the work. I wish I had done this sooner, because he did the session and realized all the work he needs to do, but it was too late for him. He literally said, I don't have the capacity to deal with all this, and he ended his life. So I think earlier is better, and there's a whole wellness perspective of this, and for me and a lot of us, like family medicine background, there's a preventive sort of elements by dealing with the trauma early, whether it's through lifestyle change or let's say other factors that we don't know, and the etiological sort of possibilities of psychological sort of problems becoming actual diseases. So I think earlier is better when we're dealing with this kind of thing. Thank you.
Thank you. We'll take one last question.
Yes. You mentioned a connection with meditation. Could you say something about that?
Yeah, I mean, in general, so actually my interest in this started when I was undergraduate student at UC Berkeley, and they did the first functional MRI imaging where you look at which regions of the brain are activated, and they studied Zen meditators with 30 years of experience and people on LSD, and they saw that it's a similar sort of change in the brain that you see. So ultimately, through a meditation type practice, which is very hard to achieve, you can essentially do the same process. It's a very similar process. I have some personal experience with that, and Dr. Karam, and we've done Vipassana, where you go for 10 days and you eliminate all distractions and do this like deep Buddhist technique. You might be able to reach a certain similar state. So this essentially gives you like quicker access to that state, and that's why a lot of times it's criticized as like a shortcut that may not have lasting changes. And I'm not talking about like cancer end of life, but more like earlier on application of this. But yeah, literally you're seeing similar pathways in the brain being activated, and a lot of the concepts sort of overlap in terms of what we practice in meditation, mindfulness, sort of this non-judgmental awareness. And actually when we train the therapists, this is what we really try to push for, is practicing a non-judgmental awareness, being able to stay present. And it's a lot of work, hours and hours sitting present with the patient and sort of helping them go through this. And that's the thing with this process, you're injecting something into the experience. It's a co-creation, and that's what's different from a typical sort of medical experience. You're really part of that experience, and so being in a mindful state actually helps you be a good facilitator for this work.
Thank you.
Thanks so
Thank
much.
you so much. I did say that was the last question. However,
Yes.
I'm not a very good timekeeper, but we do have a question on the chat, so I don't want to ignore the chat. What might be the connection between this therapy and meaning making to address spiritual distress around dying? Acceptance is a question mark.
Yeah, I mean, it's really the same thing. I mean, what we're doing is we're allowing patients to sort of take a step back and look at their life from a different lens, because it's all about how you see something. And so normally in this disease process, you're stuck in this state of suffering. It's very hard to change your perspective. And so the plasticity that you mentioned is essentially allowing you to change the way you view yourself, and through that, meaning comes up by alleviating a lot of the suffering or causes of suffering that are sitting just below your direct sort of access point to consciousness. When they come up, when you process them, you're able to see like the bigger picture, and meaning just comes out naturally as part of that. So it's really all the same process. This just helps. Yeah, thank you so much.